Okay, so now let's start session one, Health IT's impact on quality of care. The first presentation, the first contribution we are going to see is Health IT and ambulatory care quality. Will be presented by Scott Laughrey of the University of Virginia. Take it away, Scott.
My name is Scott Laughrey. As mentioned, I'm a graduate student in economics at the University of Virginia. This paper is co-authored with my dissertation advisor, Amalia Miller, as well as Catherine Tucker and Carol Rowan-Gressens. So the question we address is, how does health IT affect the quality of care in the ambulatory setting? We're going to measure ambulatory care quality using ambulatory care sensitive hospitalization rates, calculated using data from Medicare inpatient records from 2003 to 2012, and supplemental data analysis based on HCUP data. And we estimate, we get our estimates by differences in differences with county and year fixed effects, as well as county year varying controls. And the result ultimately is we find that there's a significant reduction in ambulatory care sensitive hospitalizations in counties that have greater adoption of ambulatory health IT. Why are we interested in ambulatory health IT? Well, it's been relatively neglected by policymakers. The HITECH Act creates incentives for eligible professionals and for hospitals, but not for ambulatory facilities. And yet, in spite of that, the Affordable Care Act has a significant focus on shifting care from expensive hospitals to ambulatory facilities. And this is motivated by research such as Jiang et al. 2009 that found that in 2006 alone, there are 4 million preventable hospitalizations costing $30 billion. Also, research on the effects of health IT have so far been largely focused on the hospital setting. So we're extending the literature by examining the effects in the ambulatory setting. The potential mechanisms by which health IT might affect the quality of ambulatory care, certainly improved record keeping and information flow that's been shown to have the greatest effect for patients who are switching providers or switching settings of care. Health IT in the ambulatory setting might include decision support functions that increase standardization of care, or consumer applications that involve consumers in participating in managing their own care and following treatment regimens. Our empirical approach is differences in differences. We build a county year panel using a county measure of health IT adoption and calculate ACS hospitalization rates at the county level. We control for time-varying demographic, economic, and healthcare variables. This equation, I denotes county, T denotes year, ZIT is our set of time-varying controls, and beta 1 is the parameter of interest. And in all specifications, we're going to weight by population and cluster at the county level. Our data on ambulatory health IT comes from the HIMSS Analytics database, which includes 20,000 ambulatory facilities in recent waves of the database. An important feature of the HIMSS Analytics database is it only includes ambulatory facilities that are linked to a hospital system. So this potentially limits the generalizability of our results, but it also potentially focuses our analysis on the subset of ambulatory providers that are the most, potentially have the most to gain from health IT, because they have natural partners with which to share information and improve coordination of care. We identify the health IT adoption using the contract to date in the 2012 database. Our data on ACS admissions, I said, come primarily from the Medicare inpatient standard analytic file limited data set. This includes 100% of hospitalizations of Medicare beneficiaries between 2003 and 2012. We supplement it with data from the nationwide inpatient sample and the kids inpatient database between 2000 and 2010. And we identify ACS hospitalizations using the Prevention Qualities Indicators module developed by ARC. So here's some summary statistics. I'd focus your attention on the first three. Ambulatory EMR adoption is our main treatment measure. That's an indicator of the fraction of providers in a county that have adopted an ambulatory EMR system, which is our main measure of health IT adoption in the ambulatory setting. And the mean over the sample period is 0.45, but that really increased substantially over the course of the sample period, from 0.22 in 2003 to 0.68 in 2012. The ACS count is the number of hospitalizations in a county that are identified as ACS, and the rate is our main outcome measure, and that's the number of hospitalizations per 100,000 people over the age of 65. And as you can see, our control variables include measures of healthcare provision and economic conditions in a county. So these are our main results. In each, the outcome is the ACS hospitalization rate. In the first column, the point estimate means that for an increase in the ambulatory EMR adoption in a county of 0.45, which is the mean increase we observe over the sample period, the ACS hospitalizations in that county fall by 104 per 100,000, which is about a 1.6% decrease. Column 2 includes county year controls, and that's our preferred specification, and column 3 shows that, that the result is robust to the inclusion of state-specific linear time trends. In each of these, by the way, our sample consists of about 2,500 counties. So we perform a number of robustness checks. For example, we consider whether the decrease in ACS hospitalizations are attributable to decreases in chronic versus acute hospitalizations, chronic being conditions like COPD or hypertension, and acute being bacterial pneumonia, for example. And we find that ambulatory EMR adoption reduces both. We also find significant declines if we use the ACS count as the outcome or the natural log of the ACS rate. Also, if we restrict our sample to counties that have relatively good data coverage in the HIMSS analytics database, we find that we still have this effect of reduced ACS hospitalizations associated with greater ambulatory health IT adoption. We do find differential effects by age. These results that I presented are calculated using Medicare data, and so naturally we'd wonder whether the same results can be found in younger populations or populations perhaps without insurance. So as I've mentioned, we calculate the ACS hospitalization rates again using the nationwide inpatient sample. And again, we find that for patients over the age of 65, there's a statistically significant reduction in ACS hospitalizations. But for younger adult patients in the NIS, the point estimates have the same sign, suggesting a reduction in ACS hospitalization, an improvement in quality of ambulatory care, but the magnitudes are much smaller, and the effects are not statistically significant. Also, we consider pediatric care using the kids inpatient database, and the signs of our estimates are inconsistent and statistically insignificant. So this is really an area for future research, how ambulatory health IT affects outcomes for people younger than 65, because these results that we found might suggest that the effects are really concentrated among the elderly, but it could also just result from data limitations in the HCUP data sets, which are not particularly conducive to this type of county year level analysis. So, in conclusion, our paper makes two main contributions. First, it contributes to the literature on identifying the settings in which health IT improves patient outcomes. Previous research has found improvements in the hospital setting, and we extend that literature by finding improvements in the ambulatory setting as well. Second, we contribute to the literature on identifying which patients benefit most from health IT adoption. So the literature has found that the most vulnerable patients that benefit most from continuity of care experience the greatest benefit from health IT adoption. And we find that the oldest patients benefit most from ambulatory health IT adoption. And we do make a policy contribution. Our findings suggest that we find significant reductions in ambulatory care sensitive hospitalizations resulting from introduction of ambulatory health IT. And so the HITECH Act gives incentives for eligible professionals and for hospitals, but not for ambulatory facilities. And so our research suggests that there's no reason really to exclude ambulatory facilities. And the Electronic Health Fairness Act of 2015, currently before Congress, would exempt ambulatory surgery centers from meaningful use thresholds for eligible professionals. And while there is a good argument for that, I think our results suggest that there would be a cost from dulling the incentive for health IT use in ambulatory surgical centers. Okay, thank you.
Thanks so much for having me. And you pronounce my name right, the first and the last name. I feel a little bit like the Easter Bunny or Santa Claus because I come here every year. So I don't bring any gifts, but except for these slides. But it's awesome that you keep inviting me back. So I don't know how bad it's going to get before you stop inviting me. But let me just, since I don't have that much time, let me just jump right into my comments. So this paper looks at the effect of the adoption of health IT in the ambulatory care setting on ambulatory care sensitive hospitalization rates at the county level over many years. And the identification strategy that the authors use is straightforward difference in differences, estimation. So, one immediate question I had that I didn't see in the paper was how much variation you have in adoption rates over time. So that would just be informative because that's kind of key to your identification strategy. And you could also compare early versus late adopters, right? So, for instance, if you have bunching at certain dates, that would allow you to establish more credibly that adoption was exogenous, was orthogonal to other determinants of ACS hospitalization rates. And if you compared early versus late adopters, there may be additional policy implications to be drawn from that. You would expect that early adopters might have the strongest incentive and might, as a result, or the early adopting counties might have the strongest incentive, and as a result see the strongest effects. Then again, there's a recurring discussion about the cumulative effects of health ID adoption across the country, and of course technology changes over time, so late adopters may derive a benefit there. One key assumption with difference in differences estimates is always that that the change in adoption status from not having adopted to having adopted is orthogonal to all the other possible confounders that might drive your outcomes. And one important correlate might be the adoption of health IT by hospitals and primary care physician practices in the same counties that you're looking at. So I would be interested to see if your results are robust when you include the concurrent adoption of health IT in the hospitals and practices in the counties that you're studying. And this might actually inform policy as well, because you might wonder, well, did Congress really have to fund ambulatory settings? So if it turns out that adoption of health IT by hospitals and practices was already sufficient to drive down ACS hospitalization rates, then the case for carving out special incentives for the ambulatory setting might be a little weaker than you think. It also might be helpful if you simply try to replicate what your colleagues your co-authors have done. Since you have a county-level data set, that's, I think, a really important contribution, and it's novel. Of course, it's a reduced form, and it's not quite clear. It would be nice to see if you were able to replicate the results that Miller and Tucker have found when they used facility-specific data, right? So that would be interesting to see. You mentioned yourself that it would be valuable to study the mechanism. You in the data, I believe you have broken out specific health IT functions. So to the extent that there was variation there, it might be interesting to study that, and also to relate those differential adoption patterns of various technologies to the admitting diagnoses. So because you just use a catch-all ACS hospitalization rate, if you can break that out, that would be interesting. And then finally, was it worth it, right? So your bottom line conclusion is that raising ambulatory IT adoption by 45% in a county reduced ACS admission rates by 1.6%. So if you could relate these two figures to dollar figures, then we might get a better sense of what on balance was gained by this. Of course, health IT adoption did not just possibly reduce ACS admission rates, but other outcomes. But it would just this could be a back of the envelope calculation, just to give us a sense of what on balance was gained. Thank you.
Thank you.
We don't want IT to stop to prolong our process. So my name is Ray Ray. I am a PhD candidate in economics from the City University of New York. So I am very glad to be here to be able to present my work, which is talking about the heterogeneous effect of EMR system on the hospital efficiency. So I believe many of you have heard about this. That's the IT paradox. It does not only exist in the healthcare system, it exists in many other industries as well, as economists have always been trying to find out the exact IT impact. And empirically, it has been very difficult to do, not only in healthcare market, but also in other industry. Theoretically, there is one explanation of saying why it is very hard to find any impact of the IT system, and that is called the redistribution of profit. And I would like to call it the redistribution of benefit. So when you are thinking about, once there is a new technology that is introduced into the industry, not everyone is affected in the same way. Some maybe benefit more, some may be not seeing so much of benefit, and some may be seeing the effect happening in the way that we're not hoping it's to happening. So there is this redistribution. This redistribution is hinting us one thing, and that is the potential heterogeneous effect of the IT system. So that's from the theoretical part. Empirically speaking, so Brian Hofson, the professor from MIT from the MIT Business School, they have used disaggregated level of data, and they were able to find some significant impact of IT system on several other industries, such as manufacturing. And they were saying that once you use the disaggregate level of data, it is much easier for you to identify some variations, which it is very difficult to find in an aggregate level of data. So empirically speaking, it is possible to find IT impact if we are using disaggregate level of data set. So about my data, there are two major parts. One is from the HIM Analytics from 2008, and the National Inpatient Sample from the ARC project. HCUP project. And also I'm using the AHA cross-link file to link these two together. Another file that I am using is the Dartmouth Atlas Hospital Referral Region file, and that is going to define the hospital competition market that I will be using in my identification strategy. A little bit more about the data set. I am dropping patients who are transferred from other hospitals, so I'm only looking at the patients who are originally admitted to the hospital. I drop those who are giving births at the hospital, and only keeping the hospitals that are linked between those two major sets, the HIMSS and the NIS set. And my sample finally contains more than 1,200 hospitals over 7 years. A third of the hospitals appeared only once, because NIS is a repeated cross-sectional, it's not a panel data. Another third of the hospital appeared twice during the 7 years, and the rest appears more than three times or more. And the final discharge level observations contains more than 23 million. This is to give you an idea which states are covered in my analysis. So most of the high-density states are included, except maybe for Texas, where they do not allow the identification of their hospitals, so that I cannot identify them. I cannot link them to HIMSS. The trend in the EMR adoption, I have two measurements of the EMR. One is the enterprise EMR system. The other one is the EMR system plus the CPOE. The CPOE added on to EMR system is obviously having much lower adoption rates over time, and the rate shown up here is consistent with the results that have been found in previous literature. So basically by the end of 2008, the hospitals that are adopting both EMR system and the CPOE system are about 27 to 28%. So my hypothesis here is, first of all, EMR system will reduce length of stay, because EMR system are supposed to replace the paperwork and makes the communication more efficient. And more importantly, EMR systems are supposed to reduce medical errors, to let the doctors respond to some emergency cases more efficiently. So in general, we would expect the length of stay to be reducing with the help of EMR system. And also at the same time, the U.S. hospitals are not encouraged to prolong their patients' length of stay, because they are not getting paid by how many days the patients are staying at the hospital. So they should not have any incentive to prolong the process. My second hypothesis here is that the heterogeneous effect of the EMR system, it is unreasonable to believe that all the patients who are admitted to the hospitals are affected in the same way. First of all, patients are of different demographic background. Patients are different based on their medical complexities. And also, there may be heterogeneous effect based on hospital levels. Maybe the larger the hospital is, maybe the more productive they are, and maybe they have better labor complementary to their IT system here. So the hospital characteristics may also be the source of the heterogeneous effect. There can also be a heterogeneity based on the distribution of length of stay. In other words, when you're thinking about the patients who are admitted to hospitals with only 1 day, and you compare that with the patients who are admitted to the hospital and staying for over a month, who's the one going to be affected more from the system? So that's the distributional heterogeneous effect. In previous literatures, we have seen researchers trying to find out the heterogeneity among inpatient sample, and I am citing Jeff's paper here. It is a brilliant paper. The only thing is that they have to make an ex ante assumption of how we are separating the different groups of patients. They have to make decisions saying that, okay, here is the sicker group, here is the relatively healthier group. And this paper of mine is taken from another angle, from the applied econometrics level, and I am saying I don't have to make the priori assumption here. I am only saying that I know heterogeneity exists. I am not putting any more assumptions on that, and I will let my model tell me where the source of heterogeneity comes from, because all the reasons for the heterogeneous effect, they are not mutually exclusive to each other. It can be working together. Patients' ages, patients' medical complexities, they can be working all together to determine the heterogeneity. The identification strategy in my paper is mainly using the instrumental variable. I am using the focal hospital's competitors' adoption rate 1 year ago as the instrument for the hospital's own decision of whether to adopt the system or not. And the hospital competitors are defined by the hospitals within the same HRR, the hospital referral region area. And just a little bit more of the instrumental variable here. I am using the 2-sample IV because the first stage is going to be run on the hospital level, and the second stage is on the patient level. And I'm using control function because length of stay is a highly skewed variable. It's not normally distributed. It's very skewed to the left. So I have to use control function instead of the 2-stage least square. Okay, and here's the model that I was talking about, where I don't have to put more assumptions on where the heterogeneity happens. This is called the finite mixture model. So the idea is that I'm telling the model, hey, I know there must be at least 2 types of heterogeneity, so tell me what they are. Okay, let me show you the result real quick. I want you to focus on the second column here. So basically the second column says when the hospital adopt EMRs, they will see a drop about 10% or 11% in length of stay. When the hospital adopt both EMR and the CPOE system, drop of length of stay is about 14%. Okay, here is the interesting part. Focus on 2 columns of the top right-hand side here. The first column is saying these are the part of the patients that are not being affected by the EMRs. Their drop in length of stay is about 3%, not statistically significant. The second type of patients, they're experiencing about 18% drop in length of stay, statistically significant. And similar here for the hospitals adopting EMR and CPOE system. Okay, so 2 types of patients. The first one, not being affected. The second one, being affected a lot. Who are they? That's our next question. So this is like a posterior analysis. So I'm running the likelihood of each patient to be belonging to 2 different groups, and I'm running analysis just based on the patient characteristics and also on hospital's characteristics. What I'm showing up here is saying the older the patient, more likely they are in the second group, the ones that are being affected. If the patient is Black, it's more likely they're going to be affected more by the EMR system. Medicare and Medicaid patients are more likely to be the ones who are being affected. Charlson score, the higher the Charlson comorbidity, the more possible that they are the second group. Hospital characteristics, I do not find significance here except for critical access hospital. If a hospital is a critical access hospital, they are more likely to be in the first group, the ones that are not being affected more. But others, like the owner type of the hospital size, and whether the hospital belongs to any particular system, they are not showing significance here. More information about the 2 types of patients. The first type is the blue bar. This is their distribution of length of stay. You can tell that the first type of patients are the ones who are staying at hospitals for a shorter time period, and they consist of about 77% of the entire population. Only 23% of the inpatient population here are shown to have impacted from the EMR system, and the year length of stay is distributed longer with longer tail. Here is the Charlson graph of the 2 groups. If you see it clearly, there are actually 2 rings here in the graph. All the words out here is the different categories of the Charlsons. And the yellow or the orange line here is showing up that the second group of the patients are the ones who are having higher comorbidity. I also did a quick analysis just to stratify my sample based on different diagnosis types, and I realized I can still find similar things. So for example, here we have respiratory system or circulatory system disease. For all these different type of disease, we can still see this two type of effect, the ones who are not being affected and the ones who are being affected. And the percentage is roughly the same, from 70% to 80% of the populations are not being affected more, and the rest are the ones who are really being affected. And here are just some more information on how the effect changes. Okay, so in conclusion, the implementation of EMR system can drop the length of stay by 10 to 20%. Heterogeneous effect do exist. We can find that based on different diagnoses. And the finite mixture model shows that there are at least two type of patients, the ones who are being affected more and the one who are not being affected. And majority of the population are the one who are not being affected that much. So that's my talk. Thank you.
Hi, everybody. My name is Hilal Atasoy. I'm an assistant professor at Temple University. Thank you very much for the opportunity to discuss this paper. I really enjoyed reading it, and Ray did a great job presenting it, and I actually had a little brief chance to talk to her before the presentation, so she already answered some of my questions. But so I'll start with the strengths of the paper. There are several strengths in the paper. It has a nice, interesting research question analyzing the role of EMR on length of stay of patients and how this relationship varies by patient and hospital characteristics. She's also using a rich data source, including over 20 million patient discharge records. So this allows going beyond the hospital level averages and analyzing the outcome by different patient characteristics. And also the paper used nice empirical analysis and different methods to get at endogeneity, as well as the measurement of latent heterogeneity, such as IV and the finite mixture model. And here are some comments and suggestions that I had while I was reading the paper. So the paper starts with this motivation: the relationship between hospital efficiency and EMR adoption can be subject to IT paradox. That's been widely documented for different types of firms. And length of stay is one measure of efficiency, and the majority of the paper is about how this the relationship between length of stay and EMR varies by admission types, as well as disease types of the patients. I think the paper could really benefit from tying all these back to the original question: how do we relate this back to hospital efficiency? So one suggestion on that end could be maybe looking at the readmission rates or other outcomes that can be strictly tied to the length of stay. But if that's not possible to do additional analysis, I think there needs to be a discussion at the end to see what we learned, summarize and what we learned from these. Another question in the paper is to provide the incremental value of the CPOE over other types of EMRs. And the paper is using two separate sets of regressions. In the first one, the enterprise EMRs, the more basic EMRs, and in the second one, enterprise EMR plus the CPOE adoption. And most of the specifications, the coefficients don't look all that different. And we cannot test we cannot see the statistical significance in the difference of coefficients. So I think my suggestion here is maybe to pull all of them together and include the enterprise EMR and CPOE in the regressions to be able to test the statistical difference to establish the incremental value of CPOE over other types of EMRs. Oh, okay, sure. And the same goes for the heterogeneous effects. So the paper is looking at, this part was not in the presentation, by admission type, ER admission versus non-ER admission, as well as Ray focused a lot on different types of patients that she identified as more or less more severe and less severe patients. And all these heterogeneous effects are done by subsampling the data. So my suggestion here is maybe, again, pull the data together and use an interaction variable with those dummies or those variables to be able to see whether actually the difference is statistically significant. Because, for example, we see a coefficient negative 0.18 versus negative 0.20 from two different sets of regressions. We cannot test the statistical difference in statistical significance between those. So my suggestion is, again, to pull those and use the interaction variable to establish those heterogeneous effects that are really important for the paper. So also she presents a lot of results by different types of diseases. And that's one thing I was wondering there is what do we learn from all these types of analysis? What we see is there are differences by disease types, effects differ by disease types, but does it depend on how chronic that disease or again maybe how complex that disease is? So tying all that together to the story I think would be helpful, and it's also very challenging to look through lots of different tables and different graphs by disease type. Combining all those coefficients maybe in one plot I think would be useful. And the paper uses the finite mixture model. I was not familiar with this model before. But the idea, I think my understanding is it's a model that you don't have to impose ex ante what is the heterogeneity, and the data tells you, groups the patients in this case by itself. So my question here was why we assume there are two groups of patients to begin with, if the advantage of this model is not to assume there is a certain structure. So what happens to the results? Let's say if you do 3 groups or 4 groups, or is that even possible or feasible? That I don't know the answer to that. And my last comment is about the instrumental variable. So majority, almost all of the results in the paper are based on the IV. And the paper is using the lagged EMR adoption of other hospitals in the same hospital referral region as the instrument. And the assumption here is this instrument should not be correlated with the focal hospital's length of stay besides the impact via the focal hospital's EMR adoption decision. And of course, there is no perfect IV, and one can come up with many explanations where this is not true, because these hospitals are in the same healthcare market, they're facing the same pool of patients. So when one hospital invests in EMR, they might attract a different